Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's January 2023 issue. There are 4 articles that have been selected as our Editor's Choice or Highlights articles this month. The prior issue of the Proceedings highlighted an article by Schanefeld et al. That called attention to significantly worsened clinician burnout and declining satisfaction with work-life balance during the first 2 years of the pandemic. This issue of Mayo Clinic Proceedings contains 2 articles that propose strategies that seek to improve clinician well-being and to mitigate burnout. These 2 articles comprise the editor's choice for this issue. The first article is a special article entitled Organization-Wide Approaches to Foster Effective Unit-Level Efforts to Improve Clinician Well-Being. It is authored by Dr. Tate Schanefeld and colleagues from Stanford University in Palo Alto, California. This article emphasizes the following considerations: the pivotal role of healthcare organizations in this objective, the need for a common organizational framework and culture, and system-level strategies that promote clinician well-being, the critical importance of directing such strategies to the level of the work unit, and the central role of a unit well-being leader. Strategies at the level of the work unit should identify the specific experience and needs of a given work unit, create consistent structure and processes for interventions targeting work unit well-being, integrate such initiatives with organizational improvement framework, and employ relevant metrics to assess progress of the work unit. These and other recommendations are incorporated by Schanefeld et al. Into a series of steps that may be considered by organizations as they create a framework and milieu geared to the improvement of clinician well-being. The second article is an original article entitled Impact: Evaluation of a Controlled Organizational Intervention Utilizing Influential Peers to Promote Professional Fulfillment. It is authored by Dr. Mickey Truckle and colleagues from Stanford University School of Medicine in Palo Alto, California, and the Geisel School of Medicine at Dartmouth in Hanover, New Hampshire. This article assesses the efficacy of a popular opinion leader in enabling organizational intervention intended to promote professional well-being. In this study involving Stanford University Healthcare Alliance clinics, clinics meeting the enrollment criteria were matched by size and baseline scores for gratitude and assigned to either delayed the control group or immediate intervention. Findings from surveys in 2019 after the introduction of this intervention were compared with an average baseline scores in surveys before the intervention. Trained popular opinion leaders facilitated the engagement of clinicians in interactive wellness workshops that focused on gratitude, mindfulness, cognitive reframing, and behavioral strategies. The data demonstrate that this intervention, employing a popular opinion leader-based approach, led to 75% of clinicians at intervention attending at least one workshop, and that a beneficial impact was observed in professional fulfillment and gratitude. Moreover, this intervention was associated with fewer clinicians expressing the intent to leave the organization. As is generally agreed, occupational distress in clinicians largely occurs because of challenges and adverse conditions in the work environment. In this regard, Schanefeld et al. Underscored the need for strategies within a cohesive, interacting organizational infrastructure and milieu that are directed in particular to the work unit, while Truckle et al. Point out the influential role of respected clinicians in effectively engaging colleagues in wellness interventions that foster professional fulfillment. Our first highlight this month is an original article entitled Real-World Experience of Angiotensin Receptor Neprilysin Inhibition in Reduced Ejection Fraction Heart Failure Patients with Advanced Kidney Disease. It is authored by Dr. Huyong Chang from Cheng Sin General Hospital and National Yangming Chiao Tang University, Taipei, Taiwan, and colleagues from several other Taiwanese centers and from Mayo Clinic in Rochester, Minnesota. Prior studies demonstrate that the treatment of patients with heart failure with reduced ejection fraction with angiotensin receptor neprilysin inhibitor led to less cardiovascular mortality and rates of hospitalization compared with treatment with enalapril. Such studies, however, generally excluded patients with advanced kidney disease, that is, patients with stage 4 or 5 CKD, which reflects a GFR less than 30 mL per minute. The latter not uncommonly occurs in patients with heart failure with reduced ejection fraction. The occurrence of kidney disease of such severity in heart failure with reduced ejection fraction raises the question whether angiotensin receptor neprilysin inhibitors are effective and safe in such settings. This issue is addressed by Chang et al. Using data from patients in 2 Taiwanese multi-center heart failure cohorts with similar protocols and managed by guideline-directed medical therapy. Enrollment criteria included patients with symptomatic heart failure with reduced ejection fraction who were 20 years or older and with a baseline eGFR less than 30 mL per minute. Propensity score matching was employed to adjust for confounders. After such matching, the final analysis involved 278 patients on angiotensin receptor neprilysin inhibitors and 232 patients not on these inhibitors. At 1 year, the angiotensin receptor neprilysin inhibitor group compared with the non-angiotensin receptor neprilysin inhibitor group exhibited significantly higher left ventricular ejection fraction and eGFR and significantly lower all-cause mortality and rates of hospitalization. An additional finding was that the majority of patients with advanced kidney disease tolerated these inhibitors, as permanent discontinuation of these inhibitors occurred in no more than 13.7% of treated patients, the major reasons being worsening renal impairment, hyperkalemia, or hypotension. In discussing their findings, Chang et al. Underscored the following points. First, these data are derived from real-world observations and provide needed information regarding the use of these inhibitors in heart failure with reduced ejection fraction and concomitant advanced kidney disease. Second, these inhibitors are generally well tolerated and can be safely used. Third, the use of angiotensin receptor neprilysin inhibitors was associated with improved renal function, the latter likely reflecting any one or combination of the following effects: improved left ventricular ejection fraction, the beneficial renal hemodynamic effects of higher systemic levels of atrial natriuretic peptides that attend the use of these inhibitors, and finally the recognized antioxidant and anti-inflammatory effects of these agents. Such improvement in renal function has salutary implications for heart failure itself. Dysfunction of the kidney in heart failure may vitiate protective renal responses in heart failure, thereby exacerbating heart failure and potentially driving cycles of ever worsening heart and kidney failure. Our second highlight is an original article entitled Risk of Hematological Malignancies in Elderly Patients with Ankylosing Spondylitis, a cohort study and systematic review. It is authored by Dr. Sarah Alishami and Dr. Michael Ward from the National Institutes of Health in Bethesda, Maryland. Alishami and Ward undertook this study of ankylosing spondylitis because it is recognized that diseases attended by chronic inflammation may predispose to hematologic malignancies. Using the U.S. Medicare database from 1999 to 2015, these investigators identified 3 cohorts of beneficiaries, one with ankylosing spondylitis, another with inflammatory bowel disease, a disease with immunopathogenic features similar to ankylosing spondylitis, and a control for chronic inflammation, and a third cohort with neither condition so as to serve as an unaffected control. Beneficiaries in these cohorts were 65 years of age at the time of enrollment in 1999, and those treated with TNF-alpha inhibitors during this period were excluded so as to avoid the confounding effects of such therapy. Mean duration of follow-up for these 3 groups ranged from 8 to 10 years. The findings demonstrate that the standardized incidence ratio was increased for non-Hodgkin's lymphoma, chronic lymphocytic leukemia, and multiple myeloma and ankylosing spondylitis compared with the unaffected controls, whereas the risks for such disease were comparable in ankylosing spondylitis and inflammatory bowel disease. As their study did not include analyses on younger patients, Alishami and Ward undertook a systematic review of published studies that explored the association between ankylosing spondylitis and hematologic malignancies, because such published studies largely involved young and middle-aged patients. Such a review of 21 studies revealed little or no association of ankylosing spondylitis with hematologic malignancies. 2 cohort studies reported an increased occurrence of multiple myeloma with ankylosing spondylitis, with the mean age reported for one of these studies being approximately 54 years. Among the conclusions of this study by Alishami and Ward are that such hematologic malignancies tend to occur in elderly patients with ankylosing spondylitis, but generally do not occur in young and middle-aged patients. Clinicians caring for elderly patients with ankylosing spondylitis thus need to be cognizant of this risk for these hematologic malignancies, and that such risks do not necessarily reflect the use of TNF inhibitors per se. Finally, such risks for hematologic malignancies in elderly patients with ankylosing spondylitis are reminiscent of what occurs in inflammatory bowel disease. Such congruence of findings in these 2 diseases illustrates the pro-malignant effects of immunosenescence in synergy with chronic pro-inflammatory conditions. You can access these highlights and editor's choice articles free of charge during the entire month of January. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the home page as well as through iTunes. You'll also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.